Good morning to one and all present here. I'm Dr. Preethi, first year resident, presenting my seminar on VUR, Etiology and Non-Surgical Management under the guidance of Dr. Vinay Jadhav sir. VUR represents the retrograde flow of urine from the bladder to the upper urinary tract. First, Gallen and Da Vinci had their references about VUR. As a mediator of unidirectional flow of urine from kidneys to bladder. Then Hutch in 1952 developed a relationship between VUR and chronic pyelonephritis in paraplegic patients. Then in 1959, Hodgson studied the relationship of UTI and renal scarring in case of VUR in children. Mainly coming to the inheritance and genetics, prevalence of reflux is higher in siblings, and it is usually autosomal dominant pattern of inheritance. The probable genes that are involved are PAX2, GDNF-RET, UPK3, and AGTR2 ACE. 30% of the children with UTI and 17% without infection have VUR. 76% are male. The reason of high incidence of male is in uncircumcised male. Coming to age, the incidence is 70% in less than 1 year of age, 25% in 4 years of age, 15% in around 12 years of age. As already mentioned, it is prevalence among siblings is around 32%. Prevalence may be as low as 7% in older siblings and highest 100% in identical twin siblings. Coming to the anti-reflux mechanism, first is the functional integrity of the ureter. There is an antegrade peristalsis. Then the anatomical composition. 5:1 ratio of tunnel length to the ureteral diameter in non-refluxing junctions are seen. Then is the functional compliance of the bladder. The ureterdynamic conduit propels the urine in bolus fashion in antegrade form by neuromuscular propagation of the peristaltic activity. The reflex is actively opposed. Coming to the anatomical design, at the extravesical bladder hiatus, there are 3 muscle layers of the ureter that are separate. The outer ureteral muscle merges with the outer detrusor to form the Valder sheath. This Valder sheath will contribute to form the deep trigone. The intramural ureter passively is compressed by the bladder wall during the bladder filling, preventing the urine from entering the ureter. There is adequate intramural length and fixation of the ureter between the extravesical and intravesical points is required to create this anti-refluxing compression valve. If this intravesical length of the ureter is less in case of VUR, coming to the submucosal and intravesical length in various age is given below in this table. In 1 to 3 years, it is around 7 in intravesical and submucosal is 3. In 3 to 6, it is 7 and 3. In 6 to 9 years, it is 9 and 4. And 9 to 12 years, it is 12 and 6. This is the picture comparing the normal and in case of VUR. Coming to the etiology, primary reflex. It is due to the fundamental deficiency in the function of the UV junction. The bladder and the ureter remain normal. The reflux occurs despite an adequately low pressure urine storage profile in the bladder. Length diameter ratio is almost always less than that described by Paquin, as already mentioned. Inadequate tunnel length has greater implication. Coming to the secondary reflux, there is normal function at the UV junction. It's overwhelmed. The bladder dysfunction can be congenital, acquired, or behavioral. We should consider secondary cause if only we have documented the absence at some time before its detection. Coming to the etiology, anatomical causes are PUV, prostatomegalies, uretroceles, ureteral duplication. Coming to the neurofunctional causes are neurogenic bladder, spina bifida, infant voiding patterns, dysfunctional voiding, uninhibited bladder contractions, and constipation. Coming to the grading of the VUR in MCU, we graded from 1 to 5. The mnemonic to remember this is upset kidneys drink their pee. That is, grade 1 is ureter, grade 2 is kidney, grade 3 is dilatation of ureter, pelvis and calyces, grade 4 is tortuosity, and grade 5 there is loss of papillary impression. Coming to the radionuclide classification, we grade it as grade 1 according to grade 1 of international grading system. Grade 2 is grade 2 and 3. Grade 3 is grade 4 and 5. Coming to the bladder bowel dysfunction, it is usually associated with VUR. The cause is variable. The persistence of the expected early attempts to suppress bladder contraction during the toilet training months by volation contraction of the external sphincter. If this behavior becomes prolonged or intensified, the bladder voiding pressure increases, leading to the higher risk of UTI. This is associated with higher incidence of UTI while on antibiotic prophylaxis, as well as correction of VUR with less VUR resolution at 24 months from diagnosis and reduced success of endoscopic surgeries. Coming to the clinical features, there will be features of recurrent UTI, fever, flank pain, probability of finding VUR with UTI is 29 to 50%. They can also present with renal failure in 5% of the cases and palpable renal mass. Coming to the diagnosis and evaluation, urinary microscopy and culture. In infant, placement of the adhesive urinary collection bag over the genital. Patient who voids spontaneously, we can take the clean voided midstream urine. The topical cleansing of the area to reduce the contamination and false positive culture, repeated catheterization for acquisition of the specimen, and SPC sample can be taken. Coming to the radiological evaluation, indications are children less than 5 years, all children with febrile UTI, any male with UTI regardless of the age or fever. Coming to the imaging modalities, USG, MCU, and Scintigraphy. Other modalities are Uroflowmeter and Urodynamics and Cystoscopy. Coming to the USG, the quantitative assessment of the renal dimension. It's used to monitor the renal growth, impact of any intercurrent febrile episodes on renal growth, need for further assessment of the renal function by scintigraphy or the need for correction of reflex. Degree of corticomedullary differentiation can be seen. Imaging of the perfusion abnormalities. Renal resistive index measurements can be done. Contrast and enhanced harmonic ultrasounds can be used. This is the ultrasound picture showing a large obstructive ureterocele in a patient with VUR. Coming to the MCU, we'll know the functional dynamics and structural anatomy. In static films, we see the bladder contour, ureteroceles, configuration and blunting of the calyces, urethral patency, intrarenal reflex, presence of diverticula, grade of reflex, and bladder neck anatomy. In dynamic films, in passive or active reflexes can be seen. In delayed or post-void film, in documenting the clearance of the contrast from the upper tracts. These are the few images showing various grades of VUR. First image is the grade 1 in left side, where we can see only dilatation of the ureter. Second picture shows grade 2 VUR in the upper pole moiety of the duplex system, and in lower moiety we can see grade 3. This is the image showing bilateral grade 3 VUR. On the right side we can see grade 4 VUR. There is moderate dilatation with tortuosity of the ureter, and even the pelvis and calyces are dilated. This is showing grade 5 VUR. Coming to the direct radionucleotide cystography, the radiation exposure is 1% of MCU. There is This is ideal for screening, monitoring natural history, and surgical follow-up of the reflex. Greater sensitivity is there in grade 2 to grade 5 reflex. Grade 1 reflex into the distal ureters are poorly detected through this. This is the nuclear cystograms that demonstrate grade 3 reflex. Scintigraphy DMSA can be done to detect the reflex-associated renal damage, acute pyelonephritic changes, and for follow-up of the reflex. This is the image showing right superior pole scarring in case of VUR. Coming to uroflowmetry and urodynamic study, it is to establish the bladder functioning. Lack of smoothness of the flow velocity curve implies incomplete relaxation of the bladder outlet during voiding, delays the natural history of reflex resolution, or even perpetuate reflux. Increased PVRU may be the risk factor of UTI. Coming to cystoscopy, routinely it is not mandatory. We can do it prior to surgery to confirm the orifice position, duplication, proximity of the diverticular to the orifice, urethral patency, and endoscopic management. Coming to the associated anomalies, we have PUJO. Incidence of VUR associated with PUJO is 9 to 18%, and incidence of PUJO with reflex is 0.75 to 3.6%. Second association can be ureteral duplication. Most commonly, we will see in the lower pole. It can also be associated with bladder diverticula, the outpoaching of the mucosa between detrusor muscle bundles without any true muscle backing itself. The cause of reflex will be paraureteral diverticulum. Large paraureteral diverticulum could expand within the valgus fascia and cause ureteral obstruction, project forward into the bladder and obstruct the bladder outlet. It can be associated with renal agenesis in 46% and multicystic kidney diseases in 28%. And megaureter syndrome may be present in males. And pregnancy-associated reflex will be seen in women with hypertension. Other anomalies associated can be Vactral anomalies, Charge syndrome, and imperforate anus. Coming to the spontaneous resolution, at birth, the probability of spontaneous resolution of primary reflex is inversely proportional to the initial grade. If a person is encountered at later age, resolution from any point in time forward will depend on the initial grade of the reflex. Most of the cases of low grade reflux, that is grade 1 and 2, will resolve in, this is seen in 63 to 85%. Grade 3 reflux will resolve in approximately 50% of the cases. High grade reflux, that is grade 4 and 5, will resolve in about 9 to 25%. Age has a greater significance when it comes to spontaneous resolution than the grade. The most prevalence is in neonates and younger children and will demonstrate the higher tendency to resolve in this group. This is the graph showing the percent of children with reflex and years since presentation. The curve as to how there is spontaneous resolution based on the grades. Coming to the non-surgical management, principles of management, there will be spontaneous resolution. High-grade refluxes is less likely to resolve spontaneously. Extended use of prophylactic antibiotics and watchful waiting is followed. Success rate with surgical correction is very high. Coming to the medical management, as already mentioned, watchful waiting is the method. Antibiotic prophylaxis, we can use amoxicillin or cotrimoxazole in case we are using more than 2 months. And alternatives can be nitrofurantoin and probiotics. These are the various studies that was being done to compare to know the role of the antibiotic prophylaxis, in which River trial is a good study where the children with febrile UTI who have VUR was studied. Uh, they compared the use of antibiotic prophylaxis and placebo was given. Recurrent UTI was developed in 39 out of 302 children who received prophylaxis, and among who received placebo, 72 out of 305 children developed recurrent UTI. Prophylaxis reduced the risk of recurrence by 50%. Occurrence of renal scarring did not differ significantly between the prophylaxis and placebo groups. Among 87 children with first recurrence caused by E. coli, the resistance to cotrimoxazole was 63% in prophylaxis group and 19% in placebo groups. The study concluded that among children with VUR after urinary tract infection, antimicrobial prophylaxis was associated with substantial reduced recurrence risk of recurrence, but no significant difference in renal scarring. Thank you.
Hello.
Yes, sir.
Yeah, Preethi, this was your first presentation?
Second, sir. First was
Okay.
imaging.
Okay, good. I think it was just a broad description of medical management. We could have gone still further into role of scintigraphy. When do you do a DMSA? Acute the controversies regarding acute DMSA in an acute setting, and then wait for 6 weeks. Top-down approach, bottom-up approach. So that could have been spoken. But anyway, this is just a broad view of the UTI, primary etiologies and secondary etiologies and the resolution rates.
Yes, sir.
So, Ramchandra sir.
Yeah. I thought it was a very short and crisp presentation, and
Yes, sir.
I was surprised that she could finish off so early. So anyway, there are lots of controversies when it comes to reflux, as Dr. Vinay has pointed out, and there are some experts who say that we also have seen it in our clinical practice that VUR can be probably grossly divided into two main categories. What is called as the VUR disease or the syndrome, and what is called as the VUR as a symptom. So the VUR syndrome is mostly antenatally diagnosed, mostly seen in boys. Mostly it is high-grade reflux, mostly requires surgery. The VR symptom is what is seen in UTI. Am I heard?
Yes, sir.
Am I
Yes, sir. Yes,
audible?
sir.
Yes, sir.
Yes,
Okay.
sir.
The VR symptom is what is seen in girls most commonly, in older girls, not antenatally diagnosed. And usually it is not a very high dilating reflux. It is maybe maximum grade 3, sometimes grade 4. And very often the DMSA in most of these girls will be normal, and most of these girls will have bladder and bowel dysfunction. So the frequency of UTI is quite common in these girls. In fact, that is the reason why they present. And they also are large in number, in the sense that they form almost like 80% of the patients with VUR. So when we teach VUR, generally we teach the one which I said earlier, the VUR syndrome. So many authors have said that vesicurative reflux is a classic case of what is called as a knowledge disease. A knowledge disease is when you have thousands of references for a single entity, and most of them are contradictory to each other. So you will be wondering how to take care of this knowledge disease, how to cure the knowledge disease. So that is what we are facing most often when we see the literature on VR. And for one single question, there will be more than 5 or 6 answers. That is what has been found in the case of VR. So anyway, we will discuss it in another situation maybe. One other important thing I wanted to point out, which may be interesting for the trainees, is that there are calculators which are available for accurately predicting resolution of reflux. There is one from Boston Children's Hospital. which you have to visit their website, and then you have to fill in the details, age, and all the other details, and you will get the what is the chance of this reflux resolving.
Okay, sir.
Then there is another one called as the eye reflux from Children's Hospital of Orange County, which I have, which is as an app. This is available for both iOS and Android. You can download it, and you just have to fill in the details, and you will get the percentage of resolution of reflux. It's called as eye reflux.
Sir,
So these are the
have
things
you
I
used
wanted
it,
to
sir?
point out.
Sir, have you used
So
it, sir?
eye reflux I have used it. Yeah.
Okay. So how do
Even
you
the
think
Boston Children's Hospital one also is quite nice.
is it an algorithm, sir, which predicts the resolution rates?
Yes, correct.
Okay, okay, sir.
So
We will
basically there are drop-down menus where you have to just enter,
okay,
like
sir.
age, then what is the grade of reflux, and whether boy or girl, whether there is bowel bladder dysfunction,
Okay, sir.
all those things. So it's very easy to this thing. You can just download it and see it. iReflux is the one on App Store as well as in Android Play Store, Google Play Store. And then there
Okay.
is one called as the Boston Children's Hospital Reflux Calculator, where you have to visit their website, and then you have to use the calculator on the website itself every
But
time.
this is better, sir. We can download it as an app and keep it on the mobile so that
Yeah,
we
yeah,
can.
iReflux, yes,
Sir.
iReflux.
Okay. So
I
they
think
would
it
have.
is a free. I think it is a free app, most likely. I am not very sure.
Okay, sir. Okay, sir. We will download it and let you know, sir. Because this was our early presentation, so I thought we will discuss more about the controversies, but I
Yeah,
thought
yeah,
that will be a different topic itself to discuss the controversies of the gamut of controversies that VUR presents.
yeah.
As
Correct,
you
correct,
said, so rightly
correct.
said, it's a knowledge disease. We don't even know whether we are treating patients or we are treating classic example of treating patient versus treating an image, sir.
See, it is like a very confusing statement, no?
Yes,
They
sir.
say that 90% of VR patients, when you investigate them, they will have sterile urine and they will not have had a UTI.
True, sir.
Whereas when you investigate UTI, you will find that 60% of the febrile UTIs would have some VR demonstrable.
True, sir.
That
True,
is,
sir.
you have to hunt for it.
So,
And they are talking about doing nuclear cystography, and the ultimate hunting is what is called as the PIC cystography. So that is the ultimate hunting, where you actually look for the reflux. You sort of push the
fluid.
bladder into demonstrating reflux, and then you do the injection on the table itself. It is like
Uh,
industry driven sort of this thing, PIC cystography.
that is inducing a reflex and then injecting something for the reflex.
Yes, yes, yes. PIC cystography. It's called as PIC cystography.
True, sir. I think
PIC cystography.
they keep it at the VUJ and then
At the ureteric orifice, they keep it. Yeah.
sir, and then keep on instilling fluid into it until they demonstrate that there is some
Yeah,
reflex.
it is called as a perurethral cystoscopic installation of contrast
Fantastic. True, sir.
and doing a cystography. This is usually done under general anesthesia. You cannot do
Sir.
it otherwise.
It's mentioned in Campbell as well, sir. True, sir. Sir, anything else you want to advise them, sir? As they are early into presentations, sir.
No, no, nothing. Just important thing is that we need to remember about constipation and bowel bladder dysfunction, which we usually ignore in most of our patients. We think that, oh, India, we don't have any constipation. You'll be surprised. When you do an X-ray, you will see that the bloody thing is loaded with the shit of about maybe before Christ, before Common Era, this thing. Some generations of shit will be there in the intestine.
True,
And
sir.
we'll have more shit because we eat more shit. That is why.
True, sir. Even those that can be easily picked on MCUs also, sir. When the MCUs background, there will be so much of fecal loading.
Yeah, yeah.
So, sir, if it's okay, can we end the meeting then, sir?
Yeah, yeah, sure, sure, sure.
Thank you, sir.
Yeah, yeah.
Thank you.
Thank you, Preethi. Good
Thank you,
presentation.
sir. Thank you, sir.